Erev Tov, everyone. Good evening. Erev Tov, it's good to see everybody tonight and to have you back for the next installment of our TBS Bioethics Initiative with Professor Laurie Zoloth, which is a topic tonight that we're happy to be able to arrange with our friends in Washington that would be pretty much on everybody's minds. I want to thank our founding partners who helped make these programs possible, Audrey and Yael Asbel, Kent and Kent, and we have Larry Kent here tonight, as well as the Rabbis Acts of Kindness Fund. And also, of course, Drs. Greg Bennett and Dr. Jeff Kramer, who put much time and effort and thought into these programs and help us put them together and bring wonderful scholars like Professor Zoloth here to help guide us in our thinking about these important conversations in Jewish bioethics. I also want to say a special welcome to our friend Dr. Kelly Sorensen and Dr. Meredith Goldsmith from Ursinus College, who came here with a group of students from there as well for this program. Dr. Sorensen is a bioethicist there and has helped us out with other programs in the past, and it's good to have you back, and good to have our other friends from Ursinus here, and thank you for making the trip, and good to have you out here. I also, we have someone who's not really a guest anymore tonight, but to point him out and make sure you all talk to him after the program. We're excited that we have Rabbi Brian Wexler here with us tonight. Rabbi Wexler will be officially joining us next week, but was able to make it in for the day, so we could load him up with work for the next number of years. And we're very happy to have him here and look forward to him being permanently here beginning next week and moving down in a couple of weeks. So welcome to Rabbi Wexler. I also just want to point out that, as you can see behind me, we'll have Professor Zoloth is going to be showing some slides and doing a PowerPoint presentation. We know it's going to get a little darker as it goes on, as the sun goes down. If there are people who have trouble seeing the texts that are going to get up there in a little bit, we have some copies available. And if you need a copy once we get to the text section, you can put your hands up and we'll be going around and making sure that everybody can have an in-hand paper copy if they'd like. We'll make more available afterwards if people want to take them home. And we'll also be posting them on our website, tbsonline.org/bioethics, along with the recording of this program as well, like we have with our other programs too. So if you have friends who weren't able to make it or like to revisit some of the pieces here, you can go and take a look at that and also take a look at the text that Professor Zoloth will be teaching. So, we know that our topic tonight, Justice in an Unjust World, Healthcare Policy and Jewish Bioethics, is a hot one today in our world and our society. But something like with all of these topics in bioethics is what makes them Jewish, or what does Judaism have to say about that to help inform our understanding of these complex and important issues that our society is facing, and ultimately, as well, what role should our Jewish tradition, our Jewish values have to play within our decision-making and our policy-making and the positions that we advocate as citizens in our country. Communal care for the sick is something that Jewish legal texts have seen as an obligation for communities for centuries. Perhaps this is best summed up in a responsum in a piece of literature by Rabbi Eliezer Wallenberg, who is a rabbi of Shaarei Tzedek Hospital in Israel in the 20th century, when he wrote this: "It has been enacted that in every place in which Jews live, the community sets aside a fund to care for the sick. When poor people are ill and cannot afford medical expenses, the community sends them a doctor to visit them, and the medicine is paid for by the communal fund. The community gives them food appropriate for the ill, day by day, according to the directions of the doctor." And we know that Jewish communities throughout history have indeed set up communal funds to help care for people in the community, and even Jewish hospitals when Jews were not able to get care or to practice as doctors in our country. That's why we have hospitals like Mount Sinai or Beth Israel or Montefiore and Einstein in Philadelphia, which was one of those hospitals. It opened in 1866 with the mission of providing care for the suffering poor of all religions. But we wonder, how does this history inform our understanding of the current debate on health care? It is a complex issue with many layers and trade-offs. So how do we fulfill the value of providing care for those in need while also balancing the limited resources we have and making sure that the care is provided at its highest quality? These and many other are not easy questions, but our tradition has dealt with many of them before and gives us insights into the current debate, which we will now enter into tonight. And we are blessed to have Professor Laurie Zoloth with us, who is one of the leading bioethicists in our country. Professor Zoloth was, until very recently, at Northwestern University. She has been the president of both the American Academy of Religion and the American Society for Bioethics and Humanities, and her research is in the areas of bioethics, religion and science, feminist ethics, postmodern Jewish philosophy, and ethics. She was the founding director of the Brady Program in Ethics and Civic Life at Weinberg College, and also the founding director of the Center for Bioethics, Science, and Society at Feinberg School of Medicine, which addressed issues in emerging bioscience. I did not get to know her personally, but through her work with Rabbi Elliot Dorff in a book called Jews and Genes, which is a book about genetic research and Jewish views on them, which is a wonderful collection of essays that introduced me to Professor Zoloth. And I believe this is the first time that you will be introduced in your new position, which is Dean and Margaret E. Burton Professor at the University of Chicago School of Divinity. And we say mazel tov to you on that position, and it's a wonderful honor for you to be in there, and it's a wonderful honor for us to have you here tonight. And it's my pleasure to introduce Professor Zoloth. I swear that's it. And lastly, because I'm a rabbi and I always have one more thing to say, as we've done before, Professor Zoloth will speak for about 45 minutes or so, and then we'll have an opportunity to open it up for questions and conversation. Rabbi Lindemann and I will go around with microphones. We'll have a chance to respond and react and to discuss this important issue. It's all yours.
Well, thank you very much. Now, I have to say, I love being in New Jersey, and I love being at this beautiful synagogue. I do wish I was giving this talk to the U.S. Senate. But you're close. You're so close. So, how do I work this thing? Okay. Is it working? It's not working. Okay. Go forward. No. Help. No, it's not working. It's not. Doesn't love me. But it's a beautiful picture. I actually have that scale. So. Oh, there you go. How did you do that? You double-click there. You would think these would work. I think this part might do it in the future. Okay, stand there in case. I have to say, both my late husband and one of my sons are rabbis, so I can tease them all the time. Okay, so I want to give you a plan of talk, and because I'm a bioethicist, you have to have informed consent, so you have to agree to this plan. It's not going to be a talk about the details of what's being debated, the policy that's being debated, though we could go there. I want to ask how we got here. I'm going to give you a very brief history of healthcare. I see many of you say MD besides your name, but just in case you are not familiar with the entire history of healthcare, we're going to do that. Then we're going to say, why is this a justice issue? And then which justice we need to use. Then we're going to say, well, that's liberal theory. What did Jews think about this? What did Jews think about justice? And then ask the question at the end, what do we do? What do we do when confronted with the suffering of the other? Okay. First of all, American healthcare policy is not a planned policy. It's not the same sort of plan as happens in other countries. We know that. It's sui generis. It's unique in the industrialized world. It's organic as opposed to systematic. It is built with technology and innovation. It's driven by the marketplace. We've agreed to that. It's driven by demographic changes, changes in how we eat and how we drive around. It's driven by the history of triage in war, which we're going to talk to in a minute, and by the history of labor relations. So all these things coming together to create what we think of as American healthcare system. And lest you think that death panels is a new idea, rationing has always been a part of any healthcare system. Anyone who teaches, anyone who delivers healthcare understands that every gesture is a choice to give to this person and not to that. Healthcare has always been rationed and continues to be. Now, there wasn't a formal rationing plan until medicine becomes a public act, and that idea that medicine has to happen in public is relatively new in human history. The prior idea was that your mommy took care of you, right? Or your wife took care of you, your family took care of you. The first one was I have to throw this in because of, all of our history, and it's the anniversary of Harry Potter, so we need some knights and stuff. The Knights Templar were the first ones who set up hospices. The village healers used to go with great armies. They used the first come, first served idea. The idea that persons and not diseases were treated was the common idea. And wealthy got the healthcare because that might or not be a good idea, but they got the healthcare, and the poor were left to their families. The healthcare was not a public event at all. It was a private interaction. The American Civil War begins to change this. Wars in general change how medicine is delivered. The American Civil War is still one of the greatest catastrophes in American public life because the most deaths ever, and deaths in one's own backyard. People had to decide who to take care of first. While women, great American poets, served as a nurse in the American Civil War and wrote about this, the system was first come, first serve with a vague use of rank. People would line outside the tent door, and the first person was taken, and that didn't work, right? So many people died in the Civil War. The death rate is enormously high, not because the wounds were so grievous, though they were, not only because the technology changed, but because the system wasn't triaged. It wasn't that the worst people got treated. People had to wait in line and died waiting in that line. This term, triage, which we use in modern medicine, arises, it's French. The French physicians in the Crimean War, yes, the same place that's still having a war, around Syria. French surgeons, and of course, with the assist of Florence Nightingale, which I have to mention because I'm an RN, and so Florence gets a tip of the hat. The idea was that you would decide who was the most sick and treat them in order of the necessity of their wounds. The idea is that scarcity was made transparent. You let go of the idea that everyone was going to get treated. You understood that it was scarce. You had a scarce resource, medical care, and you would send a prearranged rational planning system in an order based on a logic. The idea was the choices would be based for the first time on the clinical assessment of the physician. And this idea that the clinical assessment of the physician had to do with the increasing role of medical expertise. Now, the priorities vary. In a war, you have to get people back right away. So ironically, in a war, the person who's the least hurt gets treated first, right? And the person who's grievously wounded and needs really an ICU, in our terms, doesn't get treated often. It's the intermediate person that gets treated second. And this worked out with the rationing of penicillin when it was first invented and used in World War II, began to replace sulfa. The first people that got penicillin were who? Any ideas? People with syphilis. Because they could get right back in and go back to the guns, right? And not the people with grievous wounds, but people who were not who life-threatening wounds, but it was used routinely for people with less traumatic wounds. World War II also drives this notion of healthcare insurance because wages are frozen in the United States. And the question was how you kept people in your factory or in the building of a dam or building of ships. Ships had to be built. You needed workers to do it. And young men would go off and want to be in the war. How did you keep people in? And the way that Kaiser did it, if wages were frozen, was they began to provide healthcare insurance. And this is the first shift from healthcare as an individual or a community-based system. For Jews in America, there was a healthcare system, the Landsmannschaften societies, which were collections taken up by people who all came from the same village that you immigrated from. My ancestors came, my great-grandparents came from Kovna, and so there was a Kovna Landmannschaften society. If you might remember them, had personal experience. You paid a small fee, it was 25 cents, a year probably, and then they buried you and took care of you. The reason we have separate Jewish hospitals is because the Jewish doctors were not allowed to work in the Christian hospitals. That's why we had to have Mount Sinai, and that's why we had to have Einstein North and South, because Jewish doctors were prohibited from working on Christian bodies. So Kaiser had the first company doctors. They set up what became the HMO. Others were paid for insurance instead of increasing their wages, and this co-payment idea later gets introduced later. The fee-for-service idea, that you get paid for what you did to a patient, creates an interesting cost shift. I trained as a nurse at Einstein, actually, at James Martin Vocational Trade School in Philadelphia, part of my nefarious past. And I remember we were introduced into the sick ward, the poor ward, and the doctor that trained us opened the doors and said, these are the bodies of the deserving poor. It is your privilege to work on them. And that was because they didn't pay anything. Doctors individually did fee-for-service and used the money that they made from the wealthy to cost shift to the poor. And then all that changed. Michael Harrington, Rawls, Robert Kennedy began to think about the other America. This other America, they were uninsured. And these uninsured people that began to be a larger and larger percentage of our population were unemployed and thus didn't have those wages from, say, a place like Kaiser, didn't have the healthcare coverage that they would get in a job. They were disabled and they were old, right? If you had a job in America in 1965, you had healthcare. There was no question. Right? The only people that were outside that system, people that we now think of as Medicaid and Medicare, were people who didn't have a job or were disabled or were too old to work. It was completely tied to labor. So our public options then moved to insure them. Medicaid, SSDI, and Medicare get invented to deal with this problem of these excluded people, a group that we've seen has grown and grown. Now, in 1965, when people began to address it, life expectancy was very, very different than it is now. Most Americans worked at a job, were insured, retired, and died 2 years later, about age 67. My age now, right? That was the average life expectancy for men, and women was slightly older. Beta blockers and stents and great cancer therapies and lipid blockers change all of this. ICUs are developed after the war. Transplants become used and then routine. New small molecule drugs help too. And this expansion, high tech, has this idea that drives our healthcare expectations. Unions were also stronger in 1965, and most American workers had coverage and fought for coverage, and unions fought for this too. Offshore production then closes plants and industries. As we know, there was a rise of large employers, Walmart, for instance, who did not insure workers by and large, and suddenly full-time and able-bodied young workers also were uninsured. And that's how we got to the situation we are now, with the decoupling of work from insurance. And medicine, as more people have no coverage, meanwhile, medicine gets better and better and more expensive in this country. There's recession, there's job loss, fewer people have jobs, but there's very costly but very cool drugs invented. Lyrica, the founder of Lyrica, a lovely man, Nick Silverman, who teaches at Northwestern and donates lovely amounts of money to Northwestern. She uses Lyrica, which becomes a widespread drug that started with a very small patient population and now widely prescribed. And lawsuits, of course, as anyone who's a physician knows, the rising cost of insurance driven by the threat of lawsuits. There's 57 million people uninsured in the US before the Obamacare, ACA. 57 million people now in this category of decoupled from jobs, with no health insurance. That's the issue that's being discussed now. But when they're hurt or when they're sick, a bill called EMTALA goes in, which says you can't not treat someone. So it's not like the uninsured don't have health care. They just have the most possible expensive health care. Everybody gets treated. It's still America. We don't let people die in the hospital parking lot. We have to take them in and take care of them. But they don't have insurance, right? So therefore, again, the cost shift happens. And the idea with the ACA was you would expand Medicaid to a greater number of people, and that's that missing 23, 22 million people that on and off it, of that 57. Still not, Obamacare didn't insure everyone, still left people out, still to be sure, but in fact more poor people were covered. Our situation gets deeper because since the Obamacare went into effect, over the last few years, the new epidemic is what? It's opioids. Now the leading cause of death of people under 40 is drug overdose, a shocking change in what healthcare is needed. So different ideas emerge about what to do as these increasing new therapies are introduced. For instance, in hemodialysis machines, when hemodialysis machines were first invented, there was committees of bioethicists, ordinary people, who used to sit around and decide who was the most deserving person. I used to work at Kaiser Permanente as an ethicist, and we used to sit around and decide who would get the liver transplant of these insured people. These were very difficult. They're often class-based. If you have someone at home who can not work and take care of you, you're more likely to get a transplant or dialysis, for example. And what happened with the hemodialysis was it was so wrenching for the ethics boards. Sheila Alexander wrote an article in Life magazine called The God Committee, And she talked to a senator, and now if you have end-stage kidney disease, 100% of those people get access to hemodialysis. And one example of a single-payer decision. For drug protocols, there's often a lottery system used, another random way of distributing it. All patients equally at risk, and then there's a lottery. For sharing organs for transplantations, there's UNOS, which was developed as a ranking system for tissue. Geography is a factor, however. If you live in an area where lots of young people go fast on highways, like in the West, Utah, Colorado, Wyoming, you're more likely to get an organ because there's more car crashes of the young. So it's just a statistical variation. Now, the flu vaccine, then in the bad flu year 2004 and 2005, set up a system by the CDC, a rationing system based on the idea of a high-risk category. So we've been doing this sort of rationing all along quietly. And also we said yes to 4 things about healthcare that make curtailing the cost of healthcare extremely difficult. One is we said yes to a healthcare marketplace, to big science that needs big amounts of money, to big litigation and technology, which create medicine as a profit center, to abundant food and sweets and drinks and smoking and a lack of exercise as an acceptable lifestyle, relatively new in human history, to paying for many untested and competing choices of therapy without any system of prioritization. And finally, we said yes to a rising sense of entitlement, an ongoing search in my generation for youth, to avoiding a serious discussion of death, or to the limits of medicine. We made those decisions that make it harder. So at Northwestern and at Chicago, we essentially think about these questions. When we think about ethics, we think about big questions. What does it mean to be human? What does it mean to be free? And what must I do about the suffering of others? How ought I to live decently is the subject of modern American ethics. However, policy changes really rarely reflect these deeper commitments. Products are sold and exchanged in the healthcare marketplace. Plans vie for popularity, new science drives new demands, and then rare treatments become routine. They're not reflective of a deeper ethical conversation. So I think we need to talk about justice. Okay, so which justice? So let's consider not how we make the choices, but the moral choices that underwrite the choices we make in social policy. Now, we have core narratives that drive ethics, and you're familiar with many of them. The Good Samaritan, a shockingly anti-Semitic story, actually, like the bad Jew versus the Good Samaritan walk by, and they see someone suffering, and they pick this one person up, and the Good Samaritan, and bad Jews walk away. The Good Samaritan takes him back and pays for him to be cared for at the inn. In the life world of the Hebrew Scriptures and New Testaments, Samaritans are very, very scary guys. They're kind of like Bloods and Crips or something. They're like bad gang members. And the fact that the Jews have walked by and the scary bad guy has saved the person is meant to startle us into the necessity of caring for the poor, this disruption that's so characteristic of the New Testament. The role of the care of the widow and orphans in our scriptures, this duty for charity to the poor, these narratives drive our sense that the world should be just, that there should be rules for how you treat the poor, right? Fair enough. In a perfect world, everybody would just get what they needed, right? But we don't live in a perfect world. And scarcity drives us all the time. And in fact, there's an interesting quote from Adam Smith, who said, in a world where everything was like water, there'd be enough water for all, and we wouldn't need a system of justice. Ironically enough, now water, the scarce commodity. But in fact, it's scarcity that drives this. There's never going to be entirely enough. To understand that, the deep limitations, the deep unknowable limitations of medicine is the place to begin talking about healthcare reform. There will never be enough for everyone to have everything they need. It's just not going to happen. It's not humanly possible in a society. I want to talk briefly about the third. What happens if there were more than one wounded traveler and the Good Samaritan was wandering around? Then what happens? And this idea that ethics is not just the self and the other, but always involves the entrance of the third, is a commonplace in Jewish philosophy as well. The question of justice is a question of how you decide what's fair. In this world of scarcity, in the particular and the very important crisis of healthcare, how do we talk about it? And how far are we accountable? Are we individually accountable for justice for the poor? Are we, as a community, a Jewish community, for instance, accountable? Are we accountable as a nation? It's part of the struggle that's going on in Congress this week. So Why justice theory first? Well, because the market theory of exchange does have limits, and because planning ahead matters. One needs lifeboats. So here's how we used to think about just allocation. Who gets in the lifeboat? There weren't enough when the Titanic went down. Okay, so the standard candidates for who gets in the lifeboat are these material principles of distribution. So we could say, let's imagine that we have enough lifeboats for this section of the audience. Sorry, fellas, right? This section of the audience, there are just enough lifeboats for this section. And let's say up here is the lifeboat. How do we decide who gets in? We could just say all of them. That little section over there, there's not that many of them, right? They're the right-handers. We don't need them. This section, right? So we could do it by numerical equality. We could just say a free-for-all. We could just say first come, first serve. And everyone could rush into my lifeboat. We could say, well, there are people here who have really worked hard. And it's really important. They're hardworking people. We shouldn't have lazy people on the lifeboat. We should just have the hardworking people, right? No losers on the lifeboat, just the hardworking people. Or we could say, let's take the doctors. We need them, and they make a good social contribution. We could do it on merit or desert. We could do it on age. Oftentimes in the American healthcare system, we give more care to elderly people and less care to the poor, less care to children, in fact. All of these systems, these are standard candidates for how you distribute something. And the theory of what's fair, what's a just system, comes from your choice of these principles. Do you think it's fair to offer more care to the young or to the old? What do you think is fair? Who will bear the burden of injustice in a world of scarcity? And you can understand a theory of justice by examining the theoretical justification of these material principles and by turning to liberal democracy itself. All liberal theories share in common this idea that the individual is in a contractual relationship with the state. And you're able as an individual to make individual choices, to voluntarily give consent, and all of us are rational free agents. All of the presuppositions of liberal theory imagine that everybody in the system is rational, is free, and is able-bodied and can make choices all by themselves. So that's the underlying problem of justice. So which justice? There's four basic ideas that undergird US healthcare policy: libertarianism, utilitarianism, deontology, and egalitarianism. We're just going to look at each briefly. I want to tell you that I don't want you to choose one. Probably a good moral stance is using the understanding that many arguments are valid and that there's some situations that call for a utilitarian moment or an egalitarian moment. The question of religious ethics is historically about limiting the reach of a libertarian market theory. That's historically been the case. That's the struggle in Hebrew scriptures. That's the struggle in the New Testament. It's the struggle in the Upanishads. How do we live as free individuals in a world of scarcity when, in fact, the market exchange is so powerful? So here's libertarian theory. Libertarian theory, here's why it works. It's based on the absolute need for freedom of the individual. It's based on the idea that property, the capacity to have property, the capacity to have your own property and to mix your labor power with what you have, with your stake, right, creates wealth. And once you've mixed your labor power with your garden or with your farm, you've created wealth, and you then are entitled to it. You can give away a portion of your wealth, create 1,000 points of light, but you don't have to. It's unfortunate if someone is needy, but it's not unfair. It just might mean that they haven't worked as hard. They haven't mixed their labor power as powerfully. Now, this is a theory that's embedded in Locke. It's embedded in Thomas Jefferson, this idea of you have the right to pursue liberty, the pursuit of happiness. This ownership of crops are yours. They're brought into being by the virtue of your work. This idea is a very powerful part of American healthcare justice, and it is the basis for many arguments. Ron Paul is a libertarian, for instance, and that's one of the reasons he doesn't want a government making these decisions. Only the people that mix their labor power with property own the property. And a government can't come and make you take your property from you and give it to some other person. You've worked for it. It's yours. You can freely choose, but it can't be taken. See this? So that's the argument against these mandates. Now, the construct is your freedom is based on the freedom of free exchanges. You are a buyer, you sell something, you give something, you just need free information, you negotiate a price, and the choice and the awareness of risk is the basis of this freedom, and you don't have a duty of a state. Okay, but there's problems with this, right? Are the first holdings really free? How did you get that farm in the first place, right? Especially if you live in America. Where did that farm in Illinois come from? Who had my garden before I did it? What about physical or genetic injustice? What about if someone's stronger and they can work the farm more, and they can create more crops and therefore have more stuff, and through the unfair lottery of life, you don't, and you don't know how to do it, or you can't do it physically? Is individual freedom always the most important moral argument, or are there other arguments? And that leads us to utilitarianism. This idea of utilitarianism, the greatest good for the greatest number, works in many medical contexts. Almost all of public health, we have some public health, right? That's what they teach you in public health school. It's the greatest good for the greatest number. You make a move that's going to affect people as best you can, but in fact, if there's a minority that won't be affected by it, well, that might be okay, because the will and the needs of the majority are important. This from John Stuart Mill. It's based on the idea of consequences, that pleasure and freedom from pain are the only things that are worth being your end. And all desirable things are desirable because of pleasure, because of goodness, right? Notice the satisfaction survey is a kind of consequentialism. Notice outcomes measures, measuring if something worked by how the outcome studies is a kind of as a utilitarian system. It's not based on individual freedom, it's based on the greatest good for the greatest number. It's not rights-based. You don't have any rights in the utilitarian system. Not a right to health care, not a right to life. If your death serves the greatest good for the greatest number, we got to go for it, right? So, problems. Of course, who decides what's good, or even the greater good? Who decides that? What about minorities? And what about the fate of an individual? Like, for instance, if I wanted to take your nice rabbi and bring him home and to be my slave, right? He's smart, he went to JTS, right? Smart, and a Midwesterner, right? Useful in Chicago, right? And he would be really miserable, but maybe you'd be all really happy. Would it be right? Right? See, the flaw of utilitarianism is, of course, the system of slavery that Mill endorses, right? That the system of the problematic system of slavery, which in some cases built much of the American South. It was the greatest good for the greatest number. Northerners were really happy. Most people in America, they were happy. But individual people were oppressed, and that was wrong. And who comes to the rescue is contract theory, or the idea of a priori contracts, making deals between people, between states, and creating rules or processes that are fair. This is based in a system called deontology, or duty-based. The idea of a duty-based, now our duties come from God, for instance. Your duties don't have to come from God, they can come from some other system. But the idea that you set in place promises, you don't care about the future, you care about the past, that you have duties to others that override any consequences is really important. And this is, of course, Immanuel Kant, who looks at American slavery and says, something's really wrong with utilitarianism. The rules have to be universal for the slave and for the free man. And this brings us back to 1965, when John Rawls is thinking, and he's working on contract theory, and he says, here's how you make a just healthcare system. Pretend you have a veil of ignorance over your face. You don't know who you are. You don't know if you're rich. You don't know if you're poor. You don't know if you have a disability. You don't know if you are, the mayor of New York. You don't know who you are. Wouldn't you make a system that's best in case you turned out for the poorest, the poorest situation? This is Rawls' interesting insight. If we all got together and you didn't know your actual situation, and we had to come up with a healthcare system, wouldn't you make sure that in case you ended up vulnerable, you would be taken care of? So Rawls makes that argument, and he makes that argument to Kennedy, who takes his class, and he makes that argument then, of course, in the Great Society. The idea is that everyone has an equal right to the most extensive total system of liberties, but everybody has to have the same system. And since life isn't fair, the most goods go to people that are under conditions of poverty, the least advantage. This is called mini-max. So the problem is about how long this should go. How long do you make this correction? How long do you favor the disadvantaged? And also, as many feminists pointed out, you're not really ever behind a veil of ignorance. That's ridiculous. You always know who you are. You always know your situation. So this is a fantasy theory. Now, then comes egalitarian theories of justice. An example of an egalitarian theorist is the current Pope, Pope Francis. His idea is that every single one of us is inescapably the same. We are fundamentally equal. The most important thing about us is our equality. And this is a bootleg theory from religion, of course. We're only equal because God is our father, in that sense, our parent, and we are the children of this system. That idea, egalitarians often don't mention God. They'll take it and say, well, we're equal because we have inalienable rights. We're equal because all people should be treated equally. And this idea is that the more equal the society is, the better the society is, drives it. And that idea is that everybody's entitled to a basic decent minimum. And by the late 19th century, people say everyone should be equal, should have a basic decent minimum, or BDM. And this minimum comes to you because you are a human being. Not because you've done anything, not because you're a doctor and we need you, not because you're old or young, just because you're a human being. You have the right to this integrity, this wholeness of life. But the trouble is, the basic decent minimum keeps changing. That's one of the things the Senate's fighting about. Is prenatal care included in the basic decent minimum, right? Are beta blockers now in the basic decent minimum? How does that work, really? New technology emerges, the basic decent minimum is redefined, and as more things begin to be invented, more people feel entitled to a greater set of interventions. Now, this is the problem with liberal theory. It has limits. It doesn't have anything in it that would motivate you really to be good, right? It really does rely on the idea of an existing marketplace. And is that the best way to think about it? Is that the right language? Is there in religious texts something that we don't find in liberal theory? And yes, we have a duty and to attend to suffering, and that happiness in our theories, religious theories, arise from the life of a person not as an individual, but as a participant in a greater social world. That's in a covenant for Jews, right? As children of Christ for Christians, as members of the living community in Buddha world. There's a special role for strangers, especially women and children in these texts, that doesn't, let's clear all this. Oh well, not sure what to do here, okay. Yeah, there it is. So here's our problem, and this is where you'd have to do some work. How do you set in place a fair and just system of access to the good ends of medicine, so it ends that well, but along the way use a fair process, right? Along the way, the rules have to be fair. So it's not the ends justify the means. We want the ends to be fair. And we want the greatest good for the greatest number, but on the way, we have to take account into just and fair goals for everyone. And we live in a very unjust world, right? We just do, and we're surrounded by injustice. So, what do Jews think? Well, one place that Jews begin in considerations of justice is the following. Rabbi, will you read that text aloud? There you go.
Two people were walking along the way, and in the hand of one of them was a flask of water. If both of them drink, they die. But if one of them drinks, he reaches civilization. Ben Petura expounded, it is better that both of them should drink and die, and let not one of them see the death of his fellow. Until Rabbi Akiba came and taught that your brother may live with you. Your life takes precedence over the life of your fellow.
Okay, now it's your turn. This is Rabbi Akiba. Nice Rabbi Akiba, the hero of the Talmud. It's a little harsh, right? Anyone know why Akiba says this?
The first supposition is two people. Akiba's answer is that only one person died, and that it's a principle of saving a life, not the fact that you have to choose one over another, but you're choosing a life as opposed to
so here he's having a little utilitarian moment, right? And he's kind of saying, well, I have two people die. At least one person should live, right? Why should both people die? Right? Why should that happen? That seems sort of wasteful if one person can live, right? You with me? right? And if one person can live, why should it be the other guy? You brought the water, right? Yeah, you brought the water. So anyone here hikers? Go hiking, you bring the water, you're prepared, you got the sweater, you're off. Okay, it's New Jersey, but there's hiking. And if somebody comes, the schleb comes with you, and he's like, doesn't have a sweater, he doesn't bring any water, and then he's thirsty, do you share or not? So this text reappears in many traditions. It reappears, interestingly, in the Christian tradition. Guess what you think the Christian answer to this is? No. Christian answer. You sacrifice your water to the other, and you die, right? Very different notion of ownership. So, but this is a troubling text, right? Don't you want both of them to come? And I'm a feminist theorist. I want there'll be a caravan. You can't know, right? But notice the troubling. Someone has to die. Scarcity is real. It should be you who thought to bring water. Okay? Do you like this text? No, we're not happy. Yes. Yes. Well, yeah. So what do you think?
You have a responsibility to the greater civilization of the world. You have a responsibility to more people that are seeking this.
Okay, so this is the limits of this text, and it's a good question. This text is one of those false trolley problem questions, which have been so they used to be just something that the ethicists knew, and now everybody knows the trolley problem. So, but here's this scarce resource, and I teach it first because it's the first place that often people go to justify a marketplace solution, and it is interesting because it reappears in the Stoic tradition and the Greek tradition, this idea of scarcity in the desert, right? Okay, since you wanted brothers, here's kinship. Okay, Rabbi. So many of them to choose from, right?
If your kinsman, being in straits, comes under your authority and you hold him as though a resident alien, let him live by your side. Do not extract from him advance or accrued interest, but fear your God. Let him live by your side as your kinsman. Do not lend him money at advance interest, or give him your food at accrued interest. I am the Lord your God who brought you out of the land of Egypt to give you the land of Canaan to be your God.
Okay, Rabbi, so what do you make of that text? He's not even here yet, and I'm
yeah.
already, he's already working, right?
I'm good with this text.
You're good with the text, right? So notice these kinship texts. This is just one of many, many, many that your rabbis can tell you all about in a longer lecture on kinship and justice. Are radical, like your brother, brothers, sisters. I have one of each, right? So they come, they screw up a little. They're on your couch. They're dirty. This guy, he comes. Maybe he's a cousin. It doesn't matter. He's entitled to be there, right? This radical demand, and in many other texts. The Lord thunders at you, I will kill your children if you don't do it. You let his kids die, I'm going after your kids. These very radical demands in the text saying, if it's your brother, and by the way, the expansion of brother kin, this notion of the larger kin, maybe everyone in Israel, maybe even these resident aliens come up, everything has to be given to them. They can't have interest, right? No interest can be charged. You just give them the food, and you let them stay there. The messy guy on the, smoking on the couch, he has to stay, no matter what. Notice the very radical demand for justice here. The special intra-kinship demand. Yes?
This is just really interesting, because this one doesn't really incorporate deserving and undeserving,
Yep.
it's just deserving, and yet the one prior to this, it's funny that we also assume that if one reaches civilization, the other one dies. It never said that. It said that one reaches, said that one reaches civilization. We don't know what happened to the other. Mm-hmm. And then we also aren't really allowed to think about who actually is deserving in that situation.
Right. It doesn't matter.
We just know the fact that one will ultimately become the deserving and one will not.
Right. Well, desert in that one, it's a matter of the prudence of ownership. You're deserving. It's a bit of a libertarian text, right? If you thought to bring the water, it's your water, and one of them's going to, so that's interesting. There's not enough water, both will die. Ben Petura says if one drinks, he will die. Ben Petura is very pessimistic voice of the Talmud. Okay? So notice the difference here. This is, by the way, just heads up, when anyone tries to tell you there's a Jewish view on this, they're wrong, because there's many Jewish views. These are many texts, right? Okay. Okay, now this is text of priority. Oh, this is really hard. Okay, and the next rabbi is going to read this one. I'm handing him out too. And yet, happily we have another rabbi. Now don't laugh, it's not him reading it, this is just a faithful rendition of the Mishnah. Okay.
So it's which text am I looking at?
Text of priority.
Mishnah, the text of priority, okay.
Yeah.
Mishnah, a man takes precedence over a woman in matters concerning the saving of life and the restoration of lost property. And a woman takes precedence over a man in respect of clothing and ransom from captivity. When both were exposed to immoral degradation in their captivity, the man's ransom takes precedence over that of the woman.
So stop for a minute, I'll get back to you. What's going on in this text? This is a text about seeing, and the way we use these texts in bioethics is to see illness as if you've been taken hostage, right? You've been taken hostage. So all the people in the hospital have been taken hostage by illness, and your healthcare system has to get them out of captivity. We're going to see 3 versions of this, out of captivity. But you need a rationing system and go, what are they using first? Our Mishnah? Gender. But it's complicated, right? Only for saving of life, men seem to be more valuable than women, and restoration of lost property, of stuff, but a woman takes precedence over clothing and ransom from captivity. What are they concerned about? And then this immoral thing, men takes precedence if they're going to be raped, right? So a woman takes precedence over captivity. You get her out of captivity before a man. But if you think that in that captivity they're both going to be abused sexually, probably, the man takes precedence because the rabbis of the Mishnah think that it's more degrading for a man to be raped than a woman to be raped. I'm sorry this is the case, but this is the case. So notice the prioritization about gender, but a very subtle prioritization of gender. It's not just, men don't always get out first. I mean, and women don't always get out first. It's very complicated.
Of course, the Mishnah was written by men.
Of course. You're going to see this as we continue. Keep going to the next one.
Okay. Kohen takes precedence over a Levite over an Israelite over a bastard over a Natin over a proselyte, and a proselyte over an emancipated slave. This order of precedence applies only when all these were in other respects equal. If the bastard, however, was a scholar and the priest was an ignoramus, the learned bastard takes precedence over the ignorant high priest.
Not only did they write this as men, they wrote these as scholars, right? So I love this text, right? Even, it's really interesting because you think you have a whole class hierarchy, and then the last zinger sentence totally undermines it, right? It's really interesting. Okay, final one.
Rav Yosef taught, if you lend money to any of my people that is poor among you, my people, or a non-Jew, my people comes first. The poor or the wealthy, the poor come first. Your poor of your city, your poor come first. The poor of your city, or the poor of another city, the poor of your city come first.
Exactly. Charity begins at home. And it's really interesting because oftentimes you do feel conflicted, right? But quite frankly, colleagues, the poor of New Jersey are your responsibility before the poor of Sudan, this text says. The poor of New Jersey, the poor in your own family, the poor in your own city are your responsibility. You must deal with them first. It's a very interesting way of thinking about justice. And I see a hand. Oh, she wants a text. Okay, good. Anything else on this? Notice it's different. This is a subtle thing. If illness is something that we think of as a capture, then how do we shape our healthcare system? An interesting language. Okay, more text on captivity. But back to this other rabbi.
Caravans of men are walking down a road, and they are accosted by non-Jews who say to them, "Give us one of your number from among you, that we may kill him. Otherwise we will kill you all. Though all may be killed, they may not hand over a single soul of Israel. However, if the demand is for a specified individual like Sheba son of Bichri, they should surrender him rather than be killed." Reish Lakish stated, "He may be surrendered only if he is deserving of death, as Sheba ben Bichri." Rabbi Yochanan said, even if he is not deserving of death, as Shiva ben Bichri.
Okay, what's going on here? By the way, just these are texts, by the way, notice the tension in all of these Talmudic texts. These are the texts in the Gemara of a deeply colonized people that have lost control of the state. And now they're like surrounded by these non-Jews. And what do we do? Jews, non-Jews, how do we rank this system? Who's in, who's out, right? Are they our enemies? Are they not? Do you protect somebody at all costs, no matter what they've done? Notice here how you can think about this language. If illness is captivity, right? Does the really bad guy also get surrendered? Or even the really bad guy, Sheba, son of Bichri, horrible human being. What? Charles Manson. Does Charles Manson get health care? Or do you surrender him to death? Notice this problem here. And notice, by the way, in typical Jewish fashion, it ends in an argument. The way of thinking through things is to not to agree, right? So, okay. Text of siege, final text of siege. Okay.
It was taught, when Nebuchadnezzar went up to subjugate Jehoiakim, he went up and sat in Daphne of Antioch. The great Sanhedrin went down to greet him and asked him, "Has the time come for the temple to be destroyed?" "No," he replied, "but Jehoiakim, king of Judah, has rebelled against me. Surrender him to me, and I will depart." So they returned and told Jehoiakim, "Nebuchadnezzar demands your surrender. And is it right to act thusly?" he exclaimed. "Can you push aside a soul for a soul? Is it not written, 'Thus shalt not deliver a fugitive slave unto his master'? Did not your old one do to Sheba, son of Bichri?" They replied, when they said to Joab, "Behold, his head shall be thrown to thee over the wall." And he would not listen to him. They arose, seized him, and lowered him down over the wall, and he cut him in pieces.
Right. The Midrash is really dense and interesting and bloody. No, I just wanted to put in here, this is a Midrash from Genesis Rabbah, the great Midrash around Genesis, and this is an interesting discussion because lest you think that the last text saved Sheba, son of Bichri, this text suggests that they sacrificed him, that they killed him, right? So the interesting dispute. Okay? Last one.
Sure. Just after Rabbi Judah said, "When are these words intended to apply when he, the individual in question, is inside and they, the non-Jews, are outside? But if he is inside and they are inside, since he would be slain and they would be slain, let them surrender him so that all of them will not be slain." Okay,
so you know what's going on there. So like they're beginning to make exceptions. Like, well, he's going to die anyway. Okay, give him up, right? So notice, what do we hear from this? They're still arguing. When you read the Talmud, when you read the Mishnah, it's vividly alive for me. They're still there arguing in Yavna someplace. So notice this question, do you surrender someone to death? Is anyone's life worth less? Right? It's the question the Senate's debating. It's the question that they're debating. So, and notice it's not solved. They're not sure, right? Text of ransom, and the final one comes when the bad guys do get you. Can you go get them back? Again, this is about how much money can you spend on healthcare, essentially.
From Mishnah Gittin, chapter 4, Mishnah 6, they should not redeem captives for more than their worth for the benefit of the world, and they should not cause captives to escape for the benefit of the world. Rabbi Shimon ben Gamliel says, for the benefit of captives.
So notice these are the texts still used by the Israeli government about soldiers, right? These are the ransom texts. These were the very texts. I lifted them up because they have been used in the last few years to decide, do you give a ransom? Or here the anxiety of the text is they'll just keep stealing Jews again, over and over, and asking for bigger and bigger ransoms. It's for the sake of the world you can't redeem, right? Okay, so the tension between the sake of the world. Now, as a bioethicist, this comes up all the time. Do you keep throwing money at the baby, right, who's terribly brain damaged and has a grade 4 bleed and blah, 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 or do you ever stop for the good of the world, right? Do you ever stop because you can't chase after every single case? Do you set limits? Okay, go on. Or are some things futile, and can you just say no? And that's the struggle here, okay?
Gemara Gittin 45a, they ask them, is this for the benefit of the world? Is it because of the pressure on the community, or perhaps because they, the hostage takers, should not be encouraged to take others? Come and hear. Levi ben Darga freed his daughter for 13,000 golden denarii. Said Abaye, And who told us he did so according to the will of the sages? Perhaps he did so against the will of the sages.
Keep going. Yeah.
They should not cause captives to escape for the benefit of the world. Rabbi Shimon ben Gamliel says, for the benefit of captives. What is the difference between them? The first sage and Rabbi Shimon, the difference between them is when there is only one captive.
So when you could make a limit, essentially. So notice that the rich guy comes in and saves his daughter for gold denarius. And the question is it permissible? Is that private act permissible? Or does that too ruin the system? Again, a question. Can you have health care for the wealthy just because you can afford it that no one else has access to? Or does that act somehow do something to the world of exchange in medicine? Okay? Now, here's the one exception. They talk about this not giving up a captive, and I'm just going to read this one. It's about what happens if someone is dying or inevitably going to die, a question that comes up in bioethics a lot. What if the designated person was a trefa? Menachem Meretz says, it goes without saying that in the case of a group of travelers, here we are traveling again, if one of them was a trefa, he may be surrendered in order to save the lives of the rest, since the killer of a trefa is exempt from the death penalty. Meir specifically does not extend this to a goses, which is surprising, for a goses typically is closer to death than a person who has just been diagnosed as having an incurable illness, which is the term for a trefa. They also use it when someone has drunk a great deal, 6 calibs of beer, because they think you can't survive that. So, nevertheless, one can understand Rabbi Meir's reasoning. The goses is a living person in all respects, and hence any complicity in his or her death would be tantamount to murder. But the trefa, on the other hand, is, as it were, already dead, and hence killing a trefa does not entail capital punishment. These facts mean, for Rabbi Meir, that in a case in which many lives could be saved as a result of the death of a trefa, the latter's life does not possess the same value as that of other viable persons. Notice the darkness of this text, the desperation of this text. Now, just a brief thing about the Rodef. What if you see someone pursuing, this is the Preventative Health text, right, or public health guide, the following have to be rescued. How far do you go, right? You have to rescue from the mitzvah of not to murder or abuse another, even at the cost of the Rodef's own life. So if you see someone who's about to kill someone, you can kill him, right? He who pursues after his neighbor to kill him, you can do it. For after a male for sexual violence, or for one woman to dishonor her, you can stop her. You can stop a rape or a murder. And this comes from the law from the Gemara, that if you see your neighbor drowning, mauled by animals or attacked by robbers, he is bound to save him. And it comes because you do not stand idly by the blood of your neighbor. But is it derived from this verse? Is it not rather from elsewhere in the Torah? From whence do we know that one must rescue his neighbor from the loss of himself? From the verse, and they shall surely restore him to himself. And from that verse, I might think that it is only a personal obligation, that he's not bound to take the trouble of hiring men if he cannot rescue the neighbor himself. Therefore, this verse says he must. So if you see someone in trouble, another radical justice text, if you see a suffering other who is in trouble, you have to do everything, even if you do everything short of making yourself impoverished. These texts played out in the Shoah. In this Rabbi Mazels, who writes a responsa from the Shoah, he describes a selection conducted by the Nazis at Auschwitz, in which some 1,400 boys of less than an arbitrary height were singled out for death. Some camp inmates sought to ransom certain boys by bribing the guards, using these texts of ransom that I just showed you. However, the guards would not release any boy without capturing another to take his place. This trading in lives went on throughout the day. Then the father of one of the boys, aware that his son could be ransomed only at the expense of another life, asked Rabbi Mazels whether, under the circumstances, the Torah permitted a father to save his son's life. Rabbi Mazels did not wish to render an explicit decision in a capital case, especially with access to books of law, the counsel of other rabbis, or the calm objectivity necessary to make such a ruling. But from the rabbi's refusal, the father considered that the ransom of his son was halakhically forbidden. What text were they using besides ransom? It's the first text, right? That you couldn't. He was a Ben Petura one. You can't ransom out someone to save yourself. He had the opposite view of Rabbi Akiba, right? So, and then he gives a beautiful thing. And so, you, dear brother, look closely and consider the generosity, the perfect piety of this Jewish man. The final text I want to take a look at is the text of Communal Responsibility. This moves our justice theory from an individual choice to a collective one. So here's a little thing for Cherry Hill. Rabbi?
It has been taught, a person of wisdom should not live in a city that is empty of the following 10 things. A court of justice that imposes flagellation and decrees penalties. A communal charity fund collected by 2 and distributed by 3. A synagogue. A mikveh. A toilet. Hopefully more than one. A mohel. A surgeon. A scribe. A butcher. A school teacher. Rabbi Akiba is quoted, also several kinds of fruit, because these enlighten the vision.
That's for you. Okay, so interesting, right? This is a text when people begin for exile, when you move out. Now, Cherry Hill has all these things, I take it, right? Chicago has all these things, it's safe to live there. But notice that a doctor is in here, a surgeon, right? Way down there, not the first thing. But notice all the things that you can't just have a surgeon alone. You need all of these things to make a healthy community. And the final thing is that you can go beyond the law. Rabbi, go beyond the law with this text.
For Rabbi Yochanan said, Jerusalem was destroyed only because they gave judgments therein in accordance with biblical law. Were they then to have judged in accordance with untrained arbitrators? But say thus, because they based their judgment strictly upon biblical law and did not go beyond the requirements of the law. Lifnei Mishurat Hadin.
So Lifnei Mishurat Hadin, this notion that even if the law constrains you, even if the text is constraining, you can still go beyond the letter of the law, the final piece about justice. Hannah Arendt, someone I turn to in dark times, is really interested in this notion of the individual embedded within a community. The individual doesn't get to choose the world into which they are born, in which they live. The question is never whether an individual is good, but whether his conduct is good for the world he lives in. In the center of interest is the world, and not the self. No moral, individual, and personal stands of conduct will ever be able to excuse us from collective responsibility. This vicarious responsibility for things we have not done, this taking upon ourselves the consequences for things we are entirely innocent of, is the price we pay for the fact that we live our lives not by ourselves, but among our fellow men. And that the faculty of action, which after all is the political faculty par excellence, can be actualized only in one of the many and manifold forms of human community. This is from her posthumous book, Responsibility and Judgment. You are responsible, I am responsible for everything the Senate is going to do about healthcare, because this is the world in which I live. This is the world in which we share. There's no escaping from this collective responsibility. Whatever happens to our healthcare system, it will also be my responsibility as a participant, not just a bystander. And finally, I want to say Emmanuel Levinas, my favorite philosopher and Jewish thinker. How many of you have heard of Levinas? Oh, now you all can hear about Emmanuel Levinas. So Emmanuel Levinas grew up in a small town in Russia, in the Ukraine, was taken to France, studied, married his next-door neighbor, and went to France to study with Husserl, Husserl's last student and Heidegger's first student, and was the person who translated Heidegger's work from German into French and made him a popular professor. And then, of course, Heidegger betrays Levinas and Hannah Arendt, who he had an affair with. And Levinas goes and asks Heidegger to help him save his daughter and wife. And Heidegger, of course, refuses, turns away all of his Jewish graduate students. Levinas joins the army, right? Joins the French army, which lasts, 10 days against the Nazis, and is taken into a camp. His wife and children are hidden by another professor. He survives the camp and writes in his head one of the great books of modern Jewish philosophy, Totality and Infinity, a very dense and beautiful book written in his head. And then he gets released, and he spends almost the rest of his life teaching high school to the Jewish community of Algeria. Algerian students are sent to Paris, and he works for the Federation, basically, teaching these kids how to be high school students. And then when he's 84, he finishes his PhD and the defense is in the Sorbonne, and he ended up teaching rabbinics in the Sorbonne just for this last few years of life. And he is now considered the single most important modern Jewish philosopher, postmodern Jewish philosopher of the 20th century. He is a beautiful lyrical writer. And he says this about justice. Justice means we are responsible beyond our commitments. We are not free. You are also bound to others beyond your freedom. You are responsible for all. Your liberty is your fraternity. Your liberty is also your fraternity. He's French. This notion that you're not free, that your individual life, your freedom is really preceded by the need for justice, is a fundamental premise for Arendt and for Levinas, modern Jewish philosophy. In our choices, some do seem fairly easy, right? We think, okay, set up a system of vaccines, right? What do you need about physicals? What happens? What about new technology? Even if you could have a basic decent minimum, set up a healthcare system, here's a choice. Many choices are difficult, and we don't have formulaic answers, not from liberal theory and not from our beautiful but confusing texts. We have a collision in modern American healthcare between the scientific imperative, which I support, a marketplace justification which structures it, and with arguments from faith that suggest a radical approach to justice. We decide every day. Cardiologists, anyone? Yes, there it is. This is a trial that I was involved in, left ventricular assist device. Each little one cost $15K, probably more now. And the issue was, could you prevent fatal heart attacks if you inserted it into people who had had a first mild MI, right? Mild heart attack. And this is a device that shocks the heart, reminds it to beat, right? But the trouble is, it's unclear who would benefit and how to set up a clinical trial. And it's a very difficult decision on how would you set up a fair clinical trial, because you have to get people to volunteer to be in a trial. Do you want to pay for this? Should you pay for this very expensive trial for this device, or just give it to everybody? Or should you test all the 18-year-olds who might have the genetic defect that often causes a sudden and dramatic fatal heart attack that could be averted if they had this device? Or just do something low-cost cardiac treatment centers in your neighborhoods with the goal of preventing obesity or stopping smoking. These sorts of questions come up all the time. How do we spend a scarce healthcare dollar? What's really a good healthcare system, and what system of justice do you use? When you have this kind of decision, when you think about what the Senate should do, what your senator or congressman should do to set up a healthcare system, or if they should at all, think about each of these benefits. Think about your ideas about what you're entitled to and what you have a duty to give to others. Think about the process for making decisions. And then finally, I hope you remember these theories of justice that we've talked about tonight. Think about which one you use to make these decisions. So I want to thank you. Of course, thanks to Emmanuel Levinas and Hannah Arendt, who I could go on about all night, to Joe Hamill, who made so much of this possible, Rabbi Micah Pelt, who was very kind and read for me on cue, and the other two rabbis here, of course, to the Bioethics Initiative, Tenfold Beth Shalom, and of course, to Jeffrey Kramer, who convinced me to come to New Jersey, and I'm very glad that he did. And to the University of Chicago that's taking me in. I start July 1st, and I'm very glad that they have me, and if anyone's a University of Chicago alum, see me. Right? Okay. Thank you very much, and my best wishes for justice.
So now's the time. We have a chance to respond and ask some questions to Professor Zoloth. Rabbi Lindemann will start on that side. I'll start over here. You can raise your hand, and we'll come over. And please remember a question, and we give the sermons around here.
Got one
we
over
have
here.
one over there.
Yes.
Okay. I'm not sure that I'm comfortable with the stuff that you talked about in terms of hostages and buying them back in the relationship to medicine. Because the situations described were kind of discrete, and the invading army, if they're telling the truth, is going to leave and you're done. Whereas in medicine, a couple of decades ago, premature infants who were less than 2 kilos were kind of dicey, and less than 1 kilo you threw back. And now babies less than a kilo are routinely surviving and doing well. So the money that was spent in ransoming those babies, if you will, is now helping other babies today.
I love that example because I worked my way through philosophy school working as a nurse in the NICU. And when I started, you remember the Kennedy baby? Remember Patrick Kennedy? It was 36 weeks, right? The 36-weeker now doesn't even get, practically goes to well baby, gets in the growing, he's like hardly considered a preemie. And that baby died because in those days, that's how those 36 weeks was just, too sick. When I first started as a nurse, exactly as you said, we had babies that we now think of as mature, 28, 27, and then I saw when I left nursing to go back and began to do bioethics, we had 22 weekers at Kaiser Oakland, 22 weeks. And they, some of them did okay, right? And it was worth ransoming them, right? I believe that. Of course, the metaphor is imperfect. This is something about the method of Jewish ethics. The Talmud is not aware of NICUs. It's not aware of ventilators. And we use these texts, and that's why I use so many, to see if they work, to try this, to say, I'm just trying to create a new language of justice outside of liberal theory. Because liberal theory has failed us. It's failed us. We don't have a good system. We don't have a way to talk about what's fair. We're in a big deadlock right now. And I'm thinking perhaps the metaphors of rabbinic teachings or postmodern philosophy urges towards something else. No metaphor fix. The metaphor actually of illness as a siege, illness as captivity, comes from Elliot Dorff, one of my teachers, and great rabbi in the conservative movement, who offers that metaphor. Rabbi Emanuel Jacobowitz, from the Orthodox tradition, former chief rabbi 2 times ago of England, suggested the text of communal responsibility. And in my work, in the book that I wrote, I went for the city with 10 things. For me, that's the metaphor that's more enduring, rather than the siege text. But because it's a conservative synagogue, I thought, I'd talk a little about Elliot Dorff's work, his idea, because I think it has some power, right? And it has been used both by the Israeli government and by people in the Holocaust.
Would you comment on profit motive in all aspects, interfering with healthcare justice?
The idea that medicine is a way to make money is a particularly American idea. In most of the rest of the world, medicine is more like the library or the school system, that it's entitlement of citizenship. That of course you have someone to take care of you like you have a policeman. And that the policeman doesn't become a policeman to make a profit. He makes a living. He doesn't make a profit. And he does scary things and difficult things. And the same thing for teaching 4-year-olds or 6-year-olds or something. These are difficult jobs. We assign them to people to do, and we all partake of them equally. Being a doctor is incredibly difficult and hard. And yet there's many other very difficult and hard jobs that we think that are due to us as citizens, but we've made a decision in this country to use the marketplace model. So there's 2 ways to think about it. One way to think about it that's useful is to say, if it's going to be a marketplace model, let's make it as humane as possible. Let's make sure that no one gets harmed by it. Let's make sure that the profits are within the bounds of decency. Let's make sure that you don't make 27 times more than the President of the United States makes or something, or whatever. Maybe not now, who knows. But you know what I'm saying? There's ways to make a marketplace fair, and there's sometimes when a marketplace is fair. Is healthcare within the sphere of the market? That's a decision we've made as a country, that it is. Most other countries have made the decision that it's not in the sphere of the market. It's not a decent thing to make a profit. I was in England for my sabbatical at Cambridge, and I went in to get some antibiotics. I got a strep throat, got some antibiotics, right? And I went in, and I went to the druggist, right? And I went to gave her my prescription, and she came back, and I began fumbling with my money and handing her pounds. And she looked at me with this look of horror, as if I had was soliciting prostitution. She said, "We don't take money for medicine," and this horrified. And I explained, "I'm an American, it's about money for us." So, but I do think it's, of course, look, I'm someone who voted for Bernie Sanders and wants a single payer system. That's who I am. Do I live in a world? I'm like Hannah Arendt. I live in a world where that's not the case, where people do think that it's a kind of business, and we have to admit that in that case, we have to make it fair, it seems, a business that's decent and fair, and the scales should be not tricked with and all of that. So, yes?
The physician only accounts for 13% of the healthcare dollar.
Correct.
Or to the healthcare insurance company to receive based on making profits for their investment.
Correct. This is true. It's not the physicians that are, though the dean of every medical school does make millions, but that aside, it's actually the system of profit taking, which, by the way, that text about interest, you don't take interest off of care, right? You give them food without interest, you give them money without interest. That animates some systems of care exchanges in other countries. That notion that this is not, so having an insurance company in the middle is like having it's making a bet. Like every single month, I put down $500 on the table, right? Of my money, I bet $500. And I bet I'm gonna get sick. And every month, Blue Cross Blue Shield puts down $500, and they bet I'm gonna be fine. Right? And God willing, every month I lose my bet, but they get my money. But that's the insurance part, and that bet has nothing to do with my nice doctor, my nice dentist. Nothing. It's just a whole other system that goes on that's complicated, that grows out of the story that I told about labor, about trade unions, about a wage freeze and a growth of other benefits. And so now here we are with a very, very jerry-rigged system.
We have a question over here. Hi. In the do not stand idly by the blood of your neighbor.
Yes.
If I'm walking and I see a child drowning in a river, even if I'm wearing new shoes and
Yes.
new suit and I'm on my way to an appointment, I've got to go in and save the kid.
Right, Peter Singer tells us that, yeah.
Okay,
Yeah.
but let's say I'm walking by and there are alligators and snakes in that river and piranhas. How much risk do I have to take to save my neighbor?
Well, the rabbis tell us that you have to risk your money, right? You have to hire guys. If you can't do it alone, you got to hire men, and I guess women nowadays too, right? To help rescue your neighbor. So there's some, you can't just walk by even though it's hard and creepy and scary. Of course, if you're following Rabbi Akiba, you don't have to lose your life to save your neighbor. So there's a rate limiting step, which is if it's life endangering, you can't. But I would think you can't just walk away, leaving the poor child to be consumed by the piranhas, right? You have to try to do something, right? Emmanuel Levinas has a beautiful idea about when you have to make the wrong choice. And he says, when you have to make the wrong choice, and sometimes we do, we can't go with the alligators. We just have to make the wrong choice. What you leave behind when you go on the other road is a trace of what could have happened had you been more noble or better or something. And that trace, you just have to be aware of that failure leaves a trace. And we live in a failed world, so of course we leave mistakes behind us all the time. But that Levinas insight, I think, is very important in a situation like that. So.
Hi. I'm going to ask you to expound a little bit on the single payer.
Okay.
Could you discuss the ethics of a single payer system that guarantees basic set upon rights of care for everyone, plus the option of out-of-pocket for those that can afford it for care above and beyond what would be included in the single-payer system?
Well, that's how Israel works. Right, exactly. There's a basic decent minimum for single-payer system that everyone has access to, and then if you want to go to see a different sort of doctor or something, you can pay for that separately. So it's a troubling system. You'd want everybody to be, you want the idea of working towards a complete single payer, and that's true. I used to work for Kaiser Permanente as a bioethicist, first as a NICU nurse and then as a bioethicist. And Kaiser is a kind of single payer on a small scale, right? And everybody gets the same care. And you've worked for Kaiser, right? A Kramer kin has worked for Kaiser. And it's really good health care. And the doctors really liked being Kaiser doctors. They felt proud of what they were doing, and they delivered health care to everyone, rich and poor. People pay, that's the closest I've come to that kind of big HMO. At a certain point, Kaiser insured 1/5 of every Californian. So it came pretty close to that. And it didn't, it wasn't horrible care. It wasn't long wait. I mean, it was a working system. And people didn't do, that ransom story. People didn't give 13,000 gold denarii to get something special because they felt good about their care relationship with their physician. The physician got a good living. The physician felt stable, and it worked out well. And they didn't go outside of that system. So for me, that's an ideal we could work towards. If people go outside, because I guess I'm sort of an egalitarian sort at heart. And I do think that I want to live in a system where the $3,000 golden denarii care is available for everybody, not just for people that have had better luck in life or chosen to do, had other choices or better, richer parents or something. It makes me sad when I can't afford special health care for my kids or something. It's a loss, I think. If everyone deserves the best possible thing that a doctor can give and a nurse can give. And one of the reasons I liked working at Kaiser was I felt I was always doing that. There was no special suite like when I worked at other hospitals. Everybody got the same really good care, and people didn't feel they had to buy out of it. So, yes. Oh. It's actually the people, notice the people with power, the people that hold the technology, right?
It was ever thus.
Yeah.
What does Jewish ethics thinking say about the conflict between having a perfect, Bernie Sanders egalitarian fairness system which kind of shuns profit or eschews profit motive, in conflict with this idea that innovation costs, and ultimately innovation can reduce cost?
Mm-hmm. I'm a big believer in dramatic scientific innovation, medical research. I was the founding chair of the Howard Hughes Medical Research Institute's Bioethics Advisory Board. So I really like innovation. Yeah, everyone knows, shh. It was really beautiful to see that work. And they fund those scientists, whatever they want for 5 years. It's an extraordinary system, and it takes a lot of money. That Howard Hughes is a lot of money, right? And I do think that the men and women who I saw at Hughes didn't do it because of the money. They were driven because they were driven to do good science, right? And I see that all the time. I'm a daughter of a school teacher who taught 3rd grade, and she was driven to do a great job. I'm not so sure that I accept the fact that people wouldn't do it if they weren't, wildly well paid. British scientists aren't very well paid, and they do great stuff. It's not because they make so much more money at doing it. British academics are not very well paid. They do it. They have figured out a way to change that to some extent. Maybe because British scientists have a single-payer system to go to, and they don't have to freak out about being ill. But I do think it's hard. I think, and again, I warn you, that Jewish ethics says many things. Right? Jewish ethics is an argument. It's not like a principle. It's an argument, right? Between the tensions that exist between, of course, people wanting to do well and thinking that hard work leads to a better situation, and this deep concern for the poor. But it's important to remember, Bernie Sanders aside, the Torah is not a socialist document. Right? It's a Jewish document. It's about God. And God urges us to care for the people that are the lost ones, the vulnerable ones. I do think that one can make in that argument, and that we have to do something about that problem, that very, very difficult problem of desperate poverty in this country, that desperation that anyone who works in a modern American hospital must see and must be moved by. So.
To come back to a minute to what you were talking about before and follow up,
Mm-hmm.
you're talking about sort of egalitarianism and everybody should have access to the best. But you started out with the concept of triage. We can't afford to give everybody the best all the time.
Right.
As you said, we probably spend half of our healthcare dollars on the last year in life. So how do you balance the egalitarian good with the limited resources that exist in the real world?
Okay, so I want to say it's a great question. I want to correct one little fact, right? That number, that thing that we say that we spend the most money on people in their last year of life, that doesn't mean that we take care of old people. It means that right before you die in a terrible accident or a sick baby in a NICU, you're really using a lot of money. And you might be young, and you might be having an accident, or you might be having a sudden catastrophic illness, and we do want to spend a lot of money on you because we don't want you to die. That's sort of the premise of medicine. So of course we're going to spend a lot of money right before you die, because we're going to spend a lot of money for people who don't die at that moment. You see what I'm saying? That's why. So that doesn't mean anything, that number. It just means we try really, really hard with really, really sick and really, really injured people. Sometimes people get more care, but there's been a lot of work since those first arguments came out. And we do want to give care to old people and sick people. Like, of course we shouldn't spend money on, healthy people who are, 15 years old. I mean, God forbid they should be a year away from dying. So sometimes it's a funny fact, but there is scarcity, and there has to be triage, and there has to be rationing. So in my book, I took a long look at the Oregon Healthcare Decision-Making Project. And that's a thing where they got together all the doctors and nurses and healthcare providers and all those people not in the 13%, not insurers, but like all the asinine people who knew something about healthcare. And they put them together. They just made all the list of all the diseases that Oregonians have, which are a little different than other people because they're Oregonians. And then they made a list of the treatments for them. And they did research about how well the treatment cured the disease. So, treatment for low back pain. They decided not to fund because it doesn't work. Headache. Doesn't work to have fancy headache treatments. The headache comes and goes away. Most viral illnesses, don't spend money on those. Stop smoking programs for teens, that doesn't work, so they don't spend money on that. And they went through every single condition and disease, paired it with the treatment, said, does this treatment work? And if it didn't do anything, it wasn't funded. And they set up their healthcare, their Medicaid system along the lines. And they keep having the discussions. One of your colleagues just said, he just saw it on C-SPAN, right? People still debate what should be, and they prioritize the treatments. Most important at the top, right? Least effective at the very bottom. And then the only decision is where you draw the line. And that has to do with how much taxes you want to spend, where you draw the line. But at least the treatments are ranked. So the most effective treatments for the worst diseases, right, that work, get funded. And that's a different way to do it. That's a different way to triage, based on disease principles and not individuals' race or class standing, but on disease principles. And I'm interested in that. I think that's an interesting way to do it.
I have one back here.
So the fact is that New Jersey spends the most healthcare dollars of any state in the last 6 months of life. We are the worst spenders on fetal care.
Well, so fetal in light of what goal?
Fetal meaning we are pouring dollars that could be diverted to prenatal care, to other forms of care that would be better utilized than we're spending in the last 6 months of life. And as many of us here are medical educators, I mean, we're trying to teach the next generation of physicians not to be wasteful with these dollars and to be able to allocate, because the Medicare Trust Fund is a trust. And we've broken that trust. We misspend the money. I think Mark's comment's right on the money. And, you have a finite pot. You can't give to everyone equally. And, I think that's a real conundrum that we face as healthcare providers.
Right. I understand that there's treatments that you feel are futile to give as a physician, right? That's when they bring in the bioethicist to try to convince the family to withdraw care. That's the common cold in American bioethics. And there are times when I think, boy, what this family needs is to say goodbye, we should spend money on getting a bus ticket for all the rest of the family to come so everybody can say goodbye. That's really what they need. But sometimes they want something that's reasonable in light of their goals, not in light of our goals. And so the discussion we're having is whose goals matter. Oftentimes that's a discussion. Is it the goals of the physician, or is it the goals of the patient and family? And so we've really tried to think about the goals of the patient and family, which could be met sometimes by continuing medical care, sometimes not. But oftentimes the physicians want us just to say, this doesn't work anymore, or this doesn't work in light of my goals. So a classic case happens in neonatology, classically, where we might come to think of, physicians and nurses might come to think of a life is not worth living. We shouldn't continue radical care on this baby because it has a bad brain bleed. It's not going to. Its life isn't worth living, and therefore that renders our care for this child futile. We should allow him to die. And of course, as you know, maybe you don't know, that many deaths in modern American NICUs are arranged deaths around those discussions. But for many families, they don't care if the child is smart or if the child grows in a normalized manner, in anything. What matters to them is the life world of their baby. And it's very hard to see that that's futile. So I think in general to have a policy about futility is a problem. I think you have to really think through with the family, what is your goal? And is this care futile in light of your goal? But if you override a family's goal or a patient's goal for themselves, that's a very, very risky road. And to do it in the name of saving money renders it even more problematic. So I would think if you have those cases, call on your local ethicist and walk through it, or call me, really. I'm more than happy to think it through, because I think each individual case needs some real hard work around that. Now, do we overtreat patients? Yes, we do. I know that that's the case. And is that overtreatment wasteful? Absolutely. So to that, you're absolutely right. We have to really think about what the goals of limits in medicine are. And that's when I said we've said yes to 4 things. One of the things we said yes to was not having a serious conversation of when to stop. We just haven't had that conversation with doctors, with families, and that informed consent conversation, that advanced directive conversation is critically important to have if we're ever going to control medical care costs.
All right, this will be our last question over by
Oh, no,
Rabbi.
right.
Actually, this is very good timing to follow your discussion. Do you think that we're at a time in our civilization that we value an individual's life much greater than we ever have in society or in civilization? We have smaller families. We don't have 12 children. You have 2 children. Do you value them greater than somebody years ago? We lost 50,000 people a day in World War II. Today we lose 2,000 in a 10-year war. We look at things a lot differently.
That is such a fascinating question. I want to think about that. But I can tell you one thing. I once spent some time reading the diaries of women who came across the U.S. to go settle in the West. I'm a Westerner, so I'm interested in that. And the letters, the diary letters and the diary entries and the letters of women who've lost one of their children, even if they have 12, they're just heartrending. They're just grief-stricken beyond belief. And I don't think that they value them less. I don't think it's like, Nishka Farlow, we have 8, right? So, and the notion is that each life is incredibly precious. If you read those diaries, read those notes, read Darwin's discussion about his daughter. And he had a lot of kids. When his daughter died, it was just this devastating thing for him. He almost went mad. So I don't think that we value life differently. The idea that we've had big families in the past, it's really been only since the mid-1800s that there was enough food in the world to have big families. Babies really didn't survive much until then. So the patriarchs had bigger families, but they had like 2 wives and so. So mostly families have been small for really throughout human history. The phenomena of the 1860s on to 1920s was a brief phenomenon in human life. So I think that each child is really, I don't think it's different, but I do think that we expect more, right? We do expect more. We do expect to live longer. We do expect to work longer. I'm following, I've mentioned a few times, this new study called the TAME study, T-A-M-E. If you look it up, it's an interesting new idea that is there a drug that you could take that would make you healthier, not extend your life, not 120, but you'd be healthier. So that big problem of a lot of money at the long end of a life for elderly people, that maybe that can be addressed. So I'm excited about where medicine's going. I'm thrilled about new technology. I love all that we know about molecular genetics. I'm a big supporter of it. And I do think that, in fact, it's the human capacity for genius and for exploration and for creativity is probably our best and most important weapon in our arsenal of changing the American healthcare system. But I do think that turning to these texts to address the problem of scarcity and what you do when you face a hard decision, what's your responsibility to each individual, each endangered individual, against a world of scarcity whose rescue might be so costly that, as you said, it affects others. These texts are interesting discussions that I think bring us a new way of thinking about this that we might not have had before. So thank you for spending time with me with these texts.
We say Toda Rabah to Professor Zoloth for that very fascinating and thought-provoking presentation. There'll be more bioethics programs coming in the fall next year, more on that to come soon. Everyone is invited to continue the conversation in the Friedman Social Hall, where I'm sure there's a little bit to eat while we do that as well. And I want to thank everybody for coming and thank everyone for their help and for support. And we look forward to seeing you soon. Toda Rabah. Thank you.